Good afternoon, everyone, and welcome to today's webinar entitled New Beginnings, Managing the Challenges and Complexities of VCA Donation Cases. We're glad that all of you could join us as we have a wonderful presentation in store for you today. My name is Deanna Fenton, and I am the Program Coordinator here with the Alliance. Now, we have just a few housekeeping items to review before we begin today's presentation. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner of your screen. Now, we are recording this webinar, so we will not be opening the phone lines during today's presentation. That means that all questions must be submitted electronically using the chat feature. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Registration is currently open for our next webinar, Ethical Issues in Living Donor Transplantation, ranging from kidneys to uteri. That's coming your way on September 25th at 3 p.m. Eastern. Registration is also open for an upcoming webinar entitled Emergency, How to Prepare and Meet Regulatory Requirements. That's coming your way on October 9th at 2 p.m. Eastern. You can register for all of these webinars and more on our website at organdonationalliance.org. For those of you who may be interested in continuing education credits, we are offering 1 Step C credit and 1 nursing contact hour courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 days to claim your credit, and for Step C, you have 30 calendar days. At this point, I'd like to introduce our moderator, Amanda Habermill, manager at UNYTS. Amanda, we're so glad to have you with us today, and at this point, I'd like to turn it over to you to introduce our speakers.
Hi, thank you. We're joined by 2 wonderful speakers. Our first speaker is going to be Michael Harnois, Donation Coordinator at New England Donor Services. Michael received a Bachelor's in Science in Medical Technology at the University of Vermont and an Associate's in Science in Emergency Medicine from the New Hampshire Technical Institute. Michael has spent the last 20 years working in organ referral, surgical recovery assistance, and providing hospital education on organ donation and transplantation for several OPOs, including New England Organ Bank, LifeNet Health, and currently at New England Donor Services. Michael is a dedicated organ and tissue donation coordinator whose goals include providing consistent, quality education to potential donor hospitals to aid in the donation process, providing evaluation and medical management of the organ donor, and furthering the mission of organ and tissue donation throughout the country. Our second speaker is Samantha Endicott, who is a regional manager at New England Donor Services, where she leads a multidisciplinary team providing education and clinical donation expertise to Boston area hospitals, including 6 transplant centers. Samantha has worked in the OPO world for 15 years with experience in roles both organ and tissue donation. Her passion lies in performance improvement, and she serves on the Organ Donation Advisory Committee of all Boston transplant centers, Quality and Improvement Committees within NEDS, and is an at-large member at UNOS Pediatric Committee. Samantha holds a master's degree in public health from the University of Alabama at Birmingham and is a certified procurement transplant coordinator.
All right. Thank you so much for that introduction. We'll get started. We're going to flip the script a little bit. I'm going to speak first, and then Mike's going to take us the rest of the way through. So thank you so much for inviting us to speak about really key strategies and how to prepare your OPO as well as your hospital partners for VCA and organ recovery. Some of the objectives that we talked about are wanting to discuss some ideas for how to prepare your staff internally for these opportunities, as well as how to disseminate this information to your hospital partners. In those discussions with hospital staff, it's going to be helpful to keep in mind how this may impact them both in a positive way and also potential issues that you and they may encounter. So in that vein, we're also going to talk about some of the potential pitfalls, particularly relating to communication. As in most things, communication is incredibly key to the success of these cases, But with so many people involved, it really is a situation rife with opportunities for miscommunication, and that can really hinder your success. So to get started, what is VCA? I know we all throw this around like the myriad other abbreviations we have in this industry, but I do think it's really helpful to step back and think about what a VCA graft is. In reality, these grafts involve a lot of different structures and tissues, all of which have their own specialties in surgery, but which one team has put a lot of work and collaboration into successfully transplanting. To successfully transplant blood vessels, nerves, connective tissue, bone, skin, and design an immunosuppressive regimen that allows that graft to thrive in a recipient is truly something special and something that is really a special gift for those that receive it. Another really amazing thing to think about is the fact that we were facilitating these transplants without really much oversight for many years. It wasn't until 2014 that VCA allocation became regulated and the process became formalized in the way that other organs are, which means this work didn't really have the same structure as the rest of what we do. We didn't even have a list from which to allocate, and that really made it a lot harder to get started. So we're hoping that sharing our experience today will help more OPOs feel comfortable with moving forward with these cases. When we talk about VCA grafts, we're talking about a lot of different opportunities. Upper and lower extremity transplants, craniofacial grafts, abdominal wall transplant, genitourinary and uterine transplants have all been recognized as important gifts that should be made available for recipients. And when we talk about recipients, they're really incredible people. So I want to share a couple stories with you, and we'll talk a little bit about the importance of stories further on in this presentation. So this is Charla Nash. The story of her injury was national news in 2009 when she was attacked by a friend's pet animal, suffering devastating injuries to her face and extremities. Charla is now 7 years out from her face transplant, and you would actually have a hard time picking her out from a crowd. I've walked past her several times at the Brigham and not even realized it. It's an amazing life enhancement for her to be able to have that social aspect of her life and be able to walk around and carry on her daily activities. This is Joseph Kynan, who was enjoying a concert at a club in Rhode Island in 2003 when the pyrotechnics set the building on fire. In the panic to get out of the building, several people, including Joe, were trampled and trapped. Joe suffered horrific burns all over his body, and his injuries resulted in the amputation of his left hand. 9 years later, he received a donor hand, which you can see in the photo here. And 2 years after he received that gift, he's using that new hand to hold his newborn son. So again, a really life-enhancing and amazing gift for him to have received. So the benefits of VCA transplant are numerous, to something as simple as appearance and feeling able to function socially, to being able to return to hobbies, or in the case of Mr. Mangino here, getting back to doing chores for his wife. Richard Mangino lost all 4 extremities to sepsis, but he's thrived after his double arm transplant. And in case you're worried, he's also back to playing guitar and swimming with his grandkids. He's not just sweeping the floors. So all of these stories are part of the history of VCA transplant. And that history is longer than many may think. The first hand transplant that was a prolonged success was back in 1999, which is 15 years before the regulations governing VCA were set forth. In 2008, the Cleveland Clinic had the first successful face transplant in the U.S. In 2016, the New York Times shared the story of the first successful penis transplant in the U.S. And in 2017, a child was born after gestating within a transplanted uterus. The experience and successes have grown through the years, with 32 VCA transplants since the OPTN began tracking in the U.S. to date. So really our hope is that more OPOs and hospital partners will become a part of this history. So, getting started. You really want to start at home. For your OPO to have a successful role in VCA transplantation, you need to have internal comfort and buy-in and that really starts with finding partners. Of course, if you have VCA transplant programs in your local and regional area, that's ideal. But I know that's not the case for everybody, and that's okay. You can still make this happen. You can leverage technology and make connections. We're in this moment talking to people across the country because we have the technology. Let's use that and help more people. So if you have local programs, invite them to your office and let them share their patients' stories. Ask them about their journey in preparing to perform these transplants. I guarantee you it's a journey. And learn their goals for the program going forward. When you're meeting with them, also take that opportunity to share with them your OPO's process and goals. Talk to them about what excites you about these opportunities and your trepidation. Learn from one another. Have a dialogue. Let everybody put their priorities on the table and find a path forward. If the programs aren't local, that's okay. Get them on a conference call or a video chat. You don't have to be close to make a connection. Once you've found your shared goals, you want to make sure that everyone in your organization knows the plan. And I do mean everyone. There is not a department that will not be touched by this, and certainly all of your field staff needs to not only be aware, but be engaged, because they are going to be the face of this being a success. Partner with your VCA programs to train your staff. For us at NEDS, having the VCA team members work with our family counselors around consent was really key in finding language that's transparent while maintaining the dignity and compassion of these conversations. When we've had cases, inviting those teams to come back and share what they saw as opportunities and things that could have gone better, and to allow us to have an open dialogue about what we felt could have been done better so that the next case was even more of a success. Really what's important is having that buy-in, having that back and forth, because if your team doesn't understand the process, why it's important, they're not going to be able to get buy-in with your hospital partners. So take the time internally to allay concerns, answer questions, and build understanding so that you can give the best possible information to your external partners. So the next step is to really start laying the groundwork externally. That doesn't mean that you need to have a traveling VCA roadshow. There's only been 32 VCA transplants in the whole country in the last 4 years. So this is not something that you need to dedicate full educational sessions to. You know, I know firsthand that getting an opportunity to get in front of your ER staff or, you know, the leadership in your ICU, this is not what you want to spend your time talking about. But what does make sense is to start folding it into your existing presentations. Your goal really is to normalize these cases, because really over time this will become normal. Right now, we coordinate the recovery of a human heart from a donor, we put it in a cooler, we put it in a jet, and it goes somewhere around the country. It goes into a totally new person, and a week or two later that person goes home and lives their life. The work we already do boggles the mind, and this is just another incredible thing that we do. This is our normal, and that is what we should display to the hospital, that this is something that while we don't do it every day, we can share that every time we have a donor, we look at that list and look for this opportunity, because this is a normal part of our practice. So include VCA when you share the types of organs for transplantation. Dispel myths. I guarantee you, if you put VCA into a presentation, you're going to get questions. Share stories. A great example of this is I've had a lot of people, as I fold VCA into presentations, say to me, you know, I don't know about that face transplant. I can't imagine ever thinking that I would want to do that. And, you know, thinking that it's something, you know, I've heard the word creepy. But when I share the story of a local recipient who said that the best thing about his face transplant is that now he can feel his daughter's kisses on his face for the first time in many years, that's not creepy. That's beautiful. So these transplants save lives in a really meaningful way. They let these patients live again. And this is just another life-saving gift that a donor can give. And when we frame it that way, we are not going to encounter resistance. So you've been mentioning VCA for months, and now there's a real opportunity. The real-time education needed for these cases is enormous because these cases are so rare. Being on site is really key. Going around, educating and answering questions before people have had time to come up with their own answers is going to make this run more smoothly. There are 3 main groups that you as a hospital liaison might want to make sure get some face time and likely multiple check-ins. I've broken it down into ICU, OR, and hospital leadership. That is not in a particular order. I think all 3 of these people need attention throughout the case. So beginning in the ICU, it feels as though this is where the majority of the needs would be because this is where we spend so much of our time in a donation case. But in reality, that's not necessarily the case, particularly if you can help staff understand what very little change there will be to their process prior to the OR. So these cases, all these donors of VCA are also organ donors. Organ donors are already a labor-intensive, all the workup, all the diagnostics. And so in terms of what the bedside nurse, what the ICU physician, the respiratory therapist are going to see in these cases, it's really not much more work, if any, from a VCA standpoint. Aside from potentially some additional radiological images or some photos that, again, would be our responsibility to make sure get ordered. In general, the main issues to address are listed here on this slide. So staff need to understand that VCA is authorized separately and that the family understands the process and has decided to make this gift. I think this is where you run into the most assumptions, the most kind of projection from staff about what the family knows or understands. And so facing that head on and having a dialogue can really make this a better experience for everyone involved. We've had great success in authorizing VCA donation, and a lot of that is because families that want to help someone often want to do that in whatever ways are possible. So helping staff to understand that can save a lot of those sideline conversations. And speaking of sideline conversations, another really important piece to this is confidentiality. All donor information is confidential regardless of the gift being given, but it is still helpful to remind staff that given how rare these types of transplant are, even general and unidentified statements about a donation case can reveal more than should be said. So while it's always our responsibility to protect the confidentiality of donors and recipients, in this case it is especially worth having some upfront conversations with staff about the fact that media may become involved on the recipient side and that we wouldn't want any information, even something like knowing which hospital the donor was from, to be revealed. One other piece that may be important to your ICU, it may not, it really depends, is the duration of the case. So from an ICU perspective, the recovery portion isn't going to extend the case. However, with so few VCA programs nationally, these recipients may be traveling cross-country for the transplant. So you want to keep your hospital partners in the loop about the expected OR time because they still have an ICU to staff. It doesn't mean that we need to go up to them and say, oh, well, the recipient's in Texas and has to catch a flight at 8 a.m. tomorrow, so we can't go before 3. That's maybe a little more information than they need, but you do want to be transparent and share timing in a way that does preserve recipient confidentiality. The next area of importance, and I would say this one is the group that's going to be most impacted by these cases, is your operating room staff. Several of the same concerns apply with this group, in particular the authorization and case duration. However, they do have some special confidentiality concerns as well as a huge logistical challenge. As their liaison, your role really should be to support them. We found that providing tools and setting expectations is hugely helpful. This is a giant unknown for almost every hospital, and so being their partner in this, having that trust, telling them that you're going to walk them through this really is going to make this a lot smoother and make them a lot more comfortable. As you're communicating, don't just say the VCA team. Tell them how many people are going to be coming to this operating room. Make sure they have realistic expectations so they can choose the right room and staff appropriately. You also want to set expectations about what this is going to look like in terms of, the room setup, the visual appearance of the patient. Have an open conversation with the charge nurse about the staff that's going to be in the room and how comfortable they are with the recovery, and make sure that the staff that's there wants to be there. You want to set up direct conversations between your OR and your partner who's up on the ICU taking care of the patient, and maybe even having the transplant team speaking directly with the charge nurse or whoever's going to be pulling instrumentation, if that makes sense. the more communication, the better, and it's really the best way to set your partners up for success. Obviously, these cases are going to be a lot longer than a standard organ recovery. Be transparent about that timing so they can staff their OR. And just as in the ICU, you want to have a frank conversation about the need for confidentiality. You want to try to find a low-traffic room if there's one of an appropriate size available. If there's not, trying to kind of drape out the windows, cover things, because you don't need a lot of kind of gawkers happening. The other piece that we found can be difficult in making sure that you're kind of policing the area is making sure that the only photos being taken are done in an approved and secure manner. And having your hospital staff partners, hospital staff members be your partners in this, letting them know how pivotal their role is in the success of this entire case, and asking them to speak up if they have a question or a concern. As the hospital liaison, being able to already have those standing relationships and say to them, I want to support you in this moment. I don't want to have to retroactively address concerns. We want this to go well now, and you're the only one that can tell us what you're feeling and what your staff needs. And so when I talk about tools and resources, this is an example. This is from one of our partner transplant centers. It's a sample diagram of body position for a bilateral upper extremity recovery. Like I said, we got this from our partner center. You can make your own. You can reach out to other centers to get these types of resources. But again, it's just something that can help you set the expectation for your partner hospitals, especially those that haven't been involved in one of these cases. And as more of us make these tools and share them with one another, hopefully we can grow the pool of resources we can share with our hospital partners and raise their comfort level, as well as our own, in having these VCA cases move forward. Finally, and I say finally because this is the final group of slides, not because this is the last group you speak to, please do not neglect these people till the end, is your leadership. So these cases, VCA, particularly the recovery portion, I would say, can be difficult for less experienced staff. It can be overwhelming. There's a million surgeons. If your specialty isn't plastics or orthopedics, some of that surgery might look a little daunting. So you want to make sure that not only are you lending your support as a representative from the OPO, but that their manager has their back. Make sure the OR nurse manager knows this case is happening, feels that you have the right staff in the room, and that they will check in with their own staff and bring any concerns to you, because we all know you've gone and you've asked if there's any questions, and no, all set, and then somebody sidles up to you and says, well, she was asking me this. That's fine. That's going to happen. We want to anticipate that. We want to make sure we address it. Same thing in the ICU. You want to make sure your ICU leadership is aware of the work that's being done and the importance of maintaining confidentiality around this case. And I think both in real time, but also in the days, weeks, months to come. If this is going to be a high-profile transplant and the transplant center intends to have a press conference or other media coverage, you want to make sure your internal OPO leadership is coordinating with that hospital in a way that both acknowledges the donor and preserves that donor's confidentiality. Basically, all in all, preparing hospital staff for these cases, particularly in real time, is a lot of work. But it's work worth doing because it paves the way for your clinical partner in the ICU to work with staff through the more minute details and work to facilitate communication with the myriad transplant center and staff involved in these recoveries. If you've been in the OR for one of these cases, there can be 20, 25 people in the room at one point. And so making sure that you have those lines of communication open and that you're addressing concerns in real time is really the key to, even if you run into some bumps in the road, everybody's still leaving that case feeling like they were cared for and that everyone was on the same page and working toward the same mission. All that I've shared in the preceding slides has been from our experience at New England Donor Services. Yours may be different, but what's important is that we're out there doing it and supporting not only our hospital partners, but one another. So with that being said, let's do a VCA recovery. Turn it over to Mike.
So let's go do a VCA recovery. So the first time that I heard that word, that particular set of words on one of my cases, my heart jumped straight into my throat. The butterflies started swimming in my belly, and I was incredibly nervous. And that's completely normal. And fortunately, as time has gone on, then the next few times that I've heard those words, it became, oh, well, that's great. Let's just get to it. So let's just get to it. So this is an internal screening checklist that we have created at New England Donor Services. I strongly recommend that you folks that want to start working on one of these programs develop something very similar to it. It's just something that gets us with a standard operating procedure, so that when you do have an organ donor and it's something that you want to consider starting to offer on a regular basis with your programs, that you have a standard operating process to do it. I apologize, I know this is not a very good form to read on a PowerPoint presentation or anything like that, and it doesn't need to be anything specific to anything really, just as long as you have a standard procedure to do it. Part of that is going to be accessing the VCA waitlist from the UNET Secure Portal. Part of that is going to be looking at those and understanding how to read those, and we'll go through some of that. And some of that's going to be working with your tissue typing labs to see who needs what for cross-matching both ahead of time and after the process, and working on specific checklists for specific VCA grafts that you're going to be doing. So where do you find the list? That was a big question that has actually been asked a number of times. So this is a screenshot when you first log into the UNOS Secure Portal. When you first log in, you see all these big things up at the top, and then if you look down at the red arrow under My Data Reports, that's where you're going to be finding it. So you see the arrow pointing to My Data Reports, and then over here, it doesn't show up completely on the screen because we wanted to make sure we could actually show everyone where they could actually read it, but where this green arrow is pointed, that is the first XLS or spreadsheet that shows up for the VCA match run. And then this is an example of that. This is where it would show up here for, we actually have two OPOs here at New England Donor Services. So here is the Life Choice Donor Services service area, and this is the New England Organ Bank service area VCA candidate list. A little bit misleading, they're both exactly the same, but it shows everyone on the VCA match run for each type of VCA, and this is what that looks like. So when you first access it, this has obviously been de-identified. It shows you the region that the patient's going to show up in, the VCA candidate ID, because we all have to have those for when we are placing a VCA graft, the particular transplant center that they are listed at, the VCA organ that they are listed for, and then this actually extends further over to the side here. Again, for legibility purposes, we didn't extend it to show all of it, but it will give you an age range for your donor, or for the acceptable range for that particular recipient. It will give you skin tone, it will give you HLA type and any specific HLA antigens that patient has been sensitized to, and it will most importantly give you contact information for that particular transplant program. And then this is just a spreadsheet. So here you have upper limbs, down here is a separate tab for head and neck, over here is for abdominal wall, and over here is for other VCAs such as uterus or male genitourinary and other grafts as they become fit. And let's see here. And I just skipped too far. Authorization. Sam touched basically on this, but it's very important to share with all of your hospital partner groups that authorization for VCA transplantation is not covered by a donor designation. A lot of people have expressed great concern about that when you're signing up to be an organ donor, no one really thinks that means you're signing up to be a face donor or an arm donor. And indeed, that is not the case. You are not signing up for that. What we have at New England Donor Services is a supplemental authorization for this. Again, I apologize, this is not meant to be completely legible. It's just meant to show as an example of what one OPO has done to solve the authorization discrepancy. It's something that does have to be signed by the family. It goes through, it looks exactly the same as our regular authorization form, except for up here when you're looking at the various different grafts that are available to us as potential VCA grafts. And then here in New England, we actually have, because we do have local programs, we actually have a research program for VCA authorization, which they are currently looking into a number of different methods for recovering VCA grafts, and they are looking into research programs for that. So Brigham and Women's actually has a research protocol that we're working with them upon right now. Supplies. Who's going to bring what? That's part of your communication. So one of the things you want to discuss when you're talking to your regional or any VCA program that is coming to your region is who's going to bring what supplies. Now, at first, when New England Donor Services started doing this, our local partner programs provided us with a number of disposable supplies for our staff to bring with us into the operating room for these recoveries. And what we found was they all expired because we weren't doing enough of them, because these cases simply don't happen frequently enough. So as a result, those supplies just expired. So what we do now is those transplant programs now bring their supplies with them. Donor hospital capabilities, you want to find out when you're first going to be doing a recovery, what capabilities those hospitals have. Are you at a big major academic medical center, or are you at a little tiny community hospital? And the number of capabilities that they're going to have will vary based on your location. Will they have microscopes? Will they have plastic surgery instruments? Generally speaking, most hospitals that have a plastic surgery program can provide the needed instrumentation that you'll need. That being said, not every hospital has a plastic surgery program. So this is where you want to find out in working with your hospital services compatriots exactly what they can supply, and find out from your VCA program what they need. And that way you can, even if necessary, put the two in contact with each other so you can figure out what needs to be brought to the hospital and what is already going to be able to be provided. Storage requirements. Who's going to bring what for bringing these grafts to their various transplant programs? As you can imagine, a cooler for a heart or a cooler for a kidney is not going to be a sufficient size for a cooler for an entire arm. So you need to figure out who's going to be bringing those coolers with them. Will it be the transplant program, or will it be the OPO? Transportation requirements. Who's going to get what where? And now this is something that we do on a daily basis. We figure out complex transportation requirements for various organs, for kidneys that go across the country, for hearts and lungs that fly everywhere in our region, for livers that go who knows where. And as the allocation system scoring changes, it's going to get even more complex. This is certainly no different. It's just another organ that's going to another transplant program. But it's still something that needs to be fixed and taken care of. And then your reconstruction requirements. There's not going to be a similar reconstruction to a tissue donor. And you want to talk about that in real time with your operating room staff and with your own staff to make sure that everyone understands who's going to be bringing what reconstruction materials with them. For upper extremities, we have an upper extremity recovery graft that will be placed. We have a facial graft that will be placed over the donor. And we have examples of those to show you. And then, of course, everyone has to document interoperatively because without documentation, it just didn't happen. So So again, I apologize. This, again, is not intended to be something that is perfectly read. It's just an example of what one OPO has decided to do to tackle that particular method. The same review and receipt of donor information that you do with every organ. This is the same exact information, and it's just reviewed with a VCA recovery surgeon. Your ABO labeling and documentation validation, same process that gets done by 2 qualified healthcare professionals. You're entering the OR date. Oftentimes, the VCA recovery is going to come first, and then your organ recovery is going to come after. So you're going to have 2 separate times of when you're entering the OR date and your initial incision time. So here's our entering the OR date. If we are administering blood products, if we are going to be monitoring hemodynamics, same as we would be for any surgery, what type of graft we're recovering, the incision date, the recovery date, the back table flush, the preservation solution, the flush volume, all similar things to what we do on every other organ for every other case. It's just that these are for different grafts. Communication is so important, and it's very important on a number of levels. So one, before any event, you want to make sure that you're having conversations with your local transplant programs so that they know about these things, so that they're aware of the possibilities that these cases could be coming to their neck of the woods and are prepared to hear about them. And then you want to be speaking to them in real time when you have one of those opportunities. Once you know that you're going to be moving forward with the VCA, you want to let all of your local transplant programs that are going to be involved in this particular donor, you want to make sure that they're aware of that being the case. And keep them all up to date as you move forward. It's very important, and we found very efficient for us to have a conference call with all of our local transplant programs that are going to be involved in the recovery, or even outside the region programs that might be coming to your service area for that particular donor. Conference calls for anyone who is going to be receiving an organ from that particular donor and from all the VCA programs, everyone coming together on a conference call before the OR, hopefully well before the OR, so you can discuss what the order of things is going to be, who's going to be where and when. Do we want to have a local transplant program prepared and in the operating room during the VCA recovery, just in the event that something bad happens? We have done that in the past here in New England, where we've had an abdominal transplant surgeon at the ready in the OR, and then we've subsequently backed off some of that, where they're just maybe in the hospital, sleeping in the lounge, while we're doing all these cases that always seem to happen in the middle of the night. Do we want to have all of our programs there? Do we want to plan for people to be there at a specific time? How long does the VCA program anticipate their recovery taking? From there, how long do we anticipate the organ recovery taking place? Because we need to plan for that total amount of time to be in the operating room. And the operating room, therefore, needs to be involved in that discussion. We want to make sure that if we know that there's vasculature involved in a liver graft, oftentimes these donors are younger and healthier, and they might be split liver donors. Are they split liver and pancreas donors? Who's going to need what for vasculature to do their reconstruction? For the VCA programs, do they need specific vasculature for their reconstruction, and is that going to affect the reconstruction on your liver or your pancreas anastomosis? Or does the heart or the lung need extra vessels to make their anastomoses? All that communication can be discussed well ahead of time, because it's not in the operating room that you want to have that first discussion. We've had internal conference calls to make sure that we are putting enough people in the right places from an OPO standpoint to set this case up for success. Do we need to have additional surgical recovery people in the operating room? Do we need to have additional donation coordinator coverage in the operating room? Do we have a hospital services person who can be in the hospital during the time that we're in the ICU, or do we need to make arrangements for somebody to go to that particular hospital at that particular time? If you're doing it at a major transplant center, you may have an in-house coordinator who's already there who can work with those programs and provide that hospital services information right away. Or are you doing this at a smaller community hospital that doesn't have somebody there on a regular basis? Once those internal conference calls have happened, then again, your external conference calls to talk about all the different needs that we just talked about. Blood transfusions is something that has come up a couple of times. When you're doing an upper extremity recovery, you're going to be losing some of your blood volume because you're going to be removing the arms. Do you need to have blood transfusion? We all already routinely have blood ready for transfusion, but you want to have that communication with your transplant programs ahead of time. Are there any of these potential organ recipients or VCA recipients that are highly sensitized, and that by transfusing you could alter the HLA profile and maybe cause an immunosuppressive concern for that particular recipient? Person to person is always best when you're in the hospital during these cases. When you're first doing your initial discussions with your ICU team, with your operating room staff, with your senior leadership, you want to have routine points of communication and then updates on anything unusual. And at a bare minimum, those first conversations should be face-to-face. And then you want to establish an effective means of communication for updates during the rest of the process. What is best for that particular person? Is it a text page? Is it a phone call? Is it paging through the hospital paging system? Whatever works best for them to receive updates. Depending on where in the hospital, it could change depending on where they are. And then communication during the event, your face-to-face staff with your ICU staff, your face-to-face discussions with the OR staff, and again, face-to-face with the anesthesiologist. This particular anesthesiologist in this photo does not look like he's terribly happy. But hopefully, after we've had enough discussions with him, we'll have him smiling away. You're going to discuss your hemodynamic parameters, transfusion thresholds, body positioning, because that's going to affect how they are going to set their anesthesia up. Timing. How long are they going to be there? We've had cases that have lasted more than half a day in the operating room. That's a long time, and they're going to need to make arrangements for people to rotate in and out. Vascular access. If you're recovering bilateral upper extremities, you're no longer going to have vascular access in those upper extremities. So that access should have already been changed in the ICU, but the anesthesiologist may want to add additional vascular access given the length of time of the case, and so that he knows where he can put it and at what time he can put it. Potential pitfalls: if you don't have sufficient communication, you don't want to have these disagreements in surgery. We've all been in an operating room where the heart and lung guys are playing the game of millimeters and trying to figure out exactly who's going to take what as far as vessel length. You don't want to have that happen during these cases. You want to have all of that already hashed out in your conference calls at the beginning, well before you started the case. You don't want an abdominal recovery team coming into surgery thinking, I'm going to use the carotid arteries to make my anastomosis, only to have the facial recovery team have already used the carotid arteries. Again, blood products, what you might need to use, how much you might need to use of what, so you can have it on hold and ready. And then time expectations and requirements so that nobody is sitting around waiting in an operating room or OR lounge or physician lounge for hours and hours because we had them there at the very beginning of the case when they probably didn't need to be. Reconstruction. So there's going to be some reconstruction, but it's very important for not only your hospital partners, but for your partners with funeral homes and the medical examiner to know that this is a different type of donation. This is not a tissue donation, and this is not a tissue reconstruction. So for funeral homes and for OR staff to understand that this is not going to be a similar tissue reconstruction. We do have a facial mask that we use and upper extremity prostheses, and this is what they look like. It's just a skin-colored facial prosthetic that goes over the face. Right now, it's just a partial face in this particular example. And then this is an example of an upper extremity limb prosthesis, both a full arm and a partial arm. So as you can tell, while they're actually quite good, all things considered, they are not similar to a tissue reconstruction. So you just want to prepare people for that and tell them that this is something that's been explained to the family at the time of the initial discussion. Other considerations to concern. Are these going to be direct cremations? You want to have those conversations with the family right away. Most oftentimes they are. The visual appearance of the donor prior to reconstruction. I don't think I need to tell anyone that when you're doing a full face recovery, that the donor is going to look different after that facial recovery prior to that mask being placed on the patient. And you want to make sure that everyone's both aware of that and okay with it. You're going to have an increase of time both from the donor management but also from the OR perspective, and an increased use of resources. There's going to be more people involved in these cases than you would have in a normal standard, liver and kidney case. Funeral home. It's very good to reach out if you have a funeral home liaison or funeral homes that you work with fairly regularly, to reach out to them just to let them know that this is a possibility, that this may be coming down the road for them, as well as your medical examiner colleagues. We really need their buy-in for all of this. They have to be involved, and they need to be aware that these are possibilities. They're probably going to have the same reaction that I had when the first time I heard of this as a possibility, and my heart leapt straight into my throat. Their hearts are going to jump into their throats, and they're going to be saying, how are we going to handle this? As they become more normal and more routine, though, it'll become just another question that they'll ask of you. Reinforcement to everybody that this is a rare event. This is not something that's going to happen on a day-to-day basis. We've got, I don't know how many cases going on in New England at this point in time, and I don't think any of them are VCA donors. We didn't have any VCA donors yesterday, or the day before that, or the day before that. So this isn't something that's going to happen on a day-to-day basis, which is why Sam made the point that you don't want to make this all about VCA. You just want to start folding this into your routine education in just small pieces. Thank you very much for your attention. I really hope this was educational for you.
Thank you so much, Mike and Samantha, for such a wonderful presentation. Before I turn it back to Amanda for questions, I'd just like to remind everyone that if you do have any questions for our presenters, please be sure to submit them using that chat feature. Again, that's located in the bottom left-hand corner of your screen. Also, during this Q&A session, I'm also going to have this poll up for you guys. For those of you who are listening in a group, please complete the poll and let us know how many people were listening in your group. And at this point, I'll turn it back to Amanda to moderate the questions.
Hi, we do have a few questions. The first question is going to be, why do VCA approaches take place only after solid organ authorization has been obtained?
So that's a great question, and something that I can tell you is the way that we do it in New England, but is not necessarily the way that everyone does it, nor the way that everyone has to do it. Here in New England, we have started with doing the solid organ authorization first. A couple reasons. One being we likely wouldn't do a VCA-only recovery, although I don't know, maybe we could. But I think a big part of it is a lot of the decisions about whether a VCA program is interested in accepting that graft is based on additional information. So things such as they might need a photo, they might need x-rays, they may need additional testing to determine whether this is something that they're interested in. And so we already would have needed to obtain authorization, and so it's easier to do that, have some of those initial conversations. You know, a lot of our donors here in New England, unfortunately, are victims of the opioid epidemic. So sometimes getting those serology results back on that organ donor before we talk to the family about VCA donation, because if the patient has hepatitis, that VCA program is likely not interested. And so there are so many things that exclude a patient from VCA donation that it makes a lot more sense to us, at least, to do that solid organ donation consent, get some additional information, and screen for VCA before we talk to a family about that opportunity, because, again, it's so rare. And something as simple as tattoos could exclude a patient from VCA donation, and that's something we can easily discover on physical assessment and never have to take a family down that road of VCA conversation. And so just kind of trying to not put too much on them if it's unnecessary.
Thank you. One of the other questions are donor consideration, age, disease history, etc.
So when you access the match run for VCA grafts, as you slide over, there's actually a segment in there which will tell you the age range that they would consider for donor age for that particular recipient, any particular specific disease history that might be an exclusion for that particular donor. They'll also tell you skin tone that they're looking for, and there's actually there's a resource guide somewhere around for what specific skin tone descriptions mean what. And so that's actually covered mostly on the VCA match run. And then the other part of it is just specific conversations with the VCA programs. If you're going to be working more or less with specific programs, then it's good to have that discussion with them, and they can tell you, we really don't like smoking history for male genitourinary graft because it has a concern for the vasculature of that particular graft. That's something we've heard quite frequently from one of our transplant programs.
Thank you. We do have a couple more questions. Where did the recipients get worked up at?
So they're going to be worked up through the transplant center with whom they're working, and so what that means is they may be traveling across the country to go to a transplant center that does the type of transplantation that they are in need of. And so they may be traveling, they may be able to work through their local hospital to send, blood work or whatever additional testing, but ultimately they do need to go to the transplant center to have a lot of this workup done.
A few more questions. Is the solid organ recovery done after the VCA recovery on the same donor?
In general, that is the case. I know particularly speaking on the ones that we've done here in New England, that has been the case where we've done the VCA recovery first and then the solid organ recovery afterward. And so that's part of what factors into the great length of time that these cases can take. While the speed in which our programs locally are starting to get to has increased and they're actually working faster, those first couple of times they were taking 6-7 hours for a facial recovery. And then you tack another 6 or 7 hours for the solid organ recovery on the end of that, and now you're in the OR for half the day. So yes, in general speaking, that's the case.
Okay, we have another question. How has follow-up with hospital staff gone on these cases?
It's actually been really positive. I think, when we were talking about emphasizing how rare an event this is, another word for rare is special. And so the hospital staff that have been involved in these cases really feel like they're a part of something unique and special and that really makes a difference in the lives of recipients. I think learning those stories has been really important, even if it's not the story of this specific recipient, but learning the importance of these grafts, what it means in these patients' lives, really helps staff to know that they're part of something that's really, really special. So overall, it's been really great. In terms of the things that we hear, of course, is how many people were in the OR, the duration of the case, and that's why in my presentation, I was emphasizing the communication around that and just being transparent. And I always tell staff when I do education about any type of donation is I can never tell you exactly how long it's going to take. But what I can do is be honest with what I expect it to be and give you updates as I get new information. And so I think staff appreciate that, and when we do follow up on these cases, that's the type of thing that we hear, and we hear less and less of it with every case that we do because we're getting better at having that communication.
Thank you. We do have one more question that circles back to the recovery of the VCA on the same donor. Do the recovery teams show up at the same time?
In general, the heart and lung teams don't show up at the same time at the beginning of the VCA recovery. We have had abdominal surgeons, or at least an abdominal surgeon at the ready, or at least in the operating room, just in case something had gone bad. We don't necessarily require that anymore because our programs have gotten more comfortable working together. But one of our VCA programs, actually both of our major VCA programs here in Boston, are also abdominal transplant programs. So they can provide a surgeon should the abdominal recovery guy not want to come and wait. We would at least have somebody at the ready in the event that something were to go bad. Now, fortunately, it hasn't happened where something's gone bad, but we have had at least an abdominal surgeon at the ready. But typically, no, not all the recovery teams are there at the beginning of the VCA recovery. We try and time them so that they're all getting there for the beginning of the organ recovery.
Okay. I think that concludes all the questions. Thank you, Michael and Samantha.
Thank you for having us.
Yes, thank you. I again would like to extend our sincere thanks to you both, as well as Amanda for your time and for sharing your expertise on such an unfamiliar topic. I know I personally learned quite a bit, so I just want to thank you once again. To all of our participants, we thank you for your time as well, and we wish you a wonderful rest of your week. Take care.